Sir, we are live now. You may start.
Good evening, ladies and gentlemen. Welcome to another exciting episode of Secrets of Neurology. Today is episode 58. We are nearing very close to our 5th year of completion. I can very humbly say that this probably is one of the longest and one of the most widely participated, not just in various institutes across India, but across the world now. And today, we would also like to have the case presentation from prestigious Dr. Ram Manohar Lohia Institute of Medical Science, Lucknow. And the topic is equally interesting: rare and complicated journey of multiple cranial nerve palsy. All this has been possible because of untiring effort and coordination and motivation of our course directors, Professor Dr. Sudhir Shah and Professor Dr. Lakshmi Narasimhan, sir. At this point, I would also like to welcome the faculty and the case presentations from Department of Neurology at RML Lucknow. As we know that this starts on time and finishes on time, and normally we take roughly close to 70 to 90 minutes. An honor and privilege for somebody who is so humble but so great, Professor Dr. Sudhir Shah, sir. We know him very well, professor and HOD at prestigious SMT NHL MMC, and sir is also director of neuroscience at Sterling Hospital, Ahmedabad. Many awards and accolades, but he has always guided us to be brief. Recipient of prestigious BC Roy Award for his service to medicine, recipient of Padam Shri for his service to mankind, humanity, and contribution to science. And sir has also been awarded with Bharat Gaurav Award at Senate of France on 5th June 2024, probably one of the highest international award for an Indian. Thank you, sir, for all your continued guidance. Our second course director, Professor Dr. Lakshmi Narasimhan Ranganathan, sir, who also contributes to this entire thing untiringly. We know him pretty well, mentor, coach, and enabler to various neurologists, especially the young ones in the country, recipient of Paltussi Award, A.B. Baker's Award, Best Paper Award, but more than this, a great coach and a mentor. May I request both our program directors to take it forward from here, sir.
Thank you, Manoj. Thank you, Dr. Manoj Kumar. So, it's our privilege to welcome all of you on this continuous journey of Secrets of Neurology on the episode number 58. You will be realizing that this is we are coming to the end of 5th consecutive year. So this is one of the most adorable series across the country. I don't know about the globe, but which gives us a lot of immense satisfaction. And I'm very thankful to Dr. Ajay Kumar Singh, whom I met very briefly a few days back and requested to take up this episode. And he was very kind that he accepted. So I'm thankful to Professor HOD Dr. Ajay Kumar Singh from RML Lohia Institute of Medical Sciences, Lucknow, and his team, there's Dr. P.K. Maurya, Professor, Department of Neurology, and Dr. Sangam Singh. So I'm here to first and foremost acknowledge the help of my co-course director, Dr. R. Lakshmi Narasimhan, a profound man with tremendous knowledge and tremendous accolades, without whose help, when I look back all these 5 years, I don't think it would have been possible for me alone to continue and get so many great institutions across. So
Thank you so much.
Really, really thank Dr. Lakshmi from my heart. And equally, I want to thank Mr. Chadda and his team, Dr. Manoj Kumar, Dr. Shweta, and others who are from Celestial Division of INTAS, the global cell makers. Their endeavor in this great task is unmeasurable in the sense they have provided continuous logistic support and kind of motivation to both of us. And thanks to all the different speakers for all these 58 episodes. Most of the speakers are not repeated so far, only two, three, four times we have repeat institution. Otherwise, all different institutions of India so far we have been covering, and we hope to do so with your continuous encouragement. That is for delegates. I want to thank all the delegates for your inputs, your suggestions, your participation, and continuous guidance. So I'm here to really thank all of you from my heart for this excellent journey. I mean, this is one of the best series. Why? Because we have tremendously great cases. We have archived all them and all the cases, their discussions, their dissection, their localization, the kind of uh, presentation to the continuous learning from that particular case. All these things have been marvelous, and it will be a treasure for the years to come for all the medical students, those who want to learn neurology, maybe DM, DNB, or even students of medicine. So I'm with full satisfaction, I must acknowledge here that many people from India and across the globe, they keep on writing to us that Dr. Shah and Dr. Lakshmi, we both are doing a very good service. And I want to pass on that credit to all of you, and particularly entire Celestial Division and all the speakers and delegates. Thank you very much. Now, today, the presenting institute is Ram Manohar Lohia Institute of Medical Science, Lucknow, one of the very important premier medical college. And Dr. Sangam Singh, a young budding neurologist in making, of course. Uh, he is going to present the case. Multiple cranial nerves, and the I have the previous slide, please. He is MBBS from IPGM. No, yes, that's right. He is MBBS from IPGMR and SSKM Hospital, Kolkata in 2016. Then he did his medicine, general medicine from BRD Medical College, Gorakhpur. And then he's pursuing now his DM neurology, the third year resident at the same institute. That is Ram Manohar, today's institute. Dr. P.K. Maurya, a very prominent neurologist from the institute who is very sharp, known for his sharp vision and wonderful clinical acumen. He's a professor from the same department of neurology, and he has 15 years experience. He has 62 publications in national international journals. He's a member of Indian Academy of Neurology, member of Critical Care Neurology, member of Indian Epilepsy Association UP chapter, and life member of IMA. And he has 8 book chapters to his credit and has been reviewed for 8 journals. That's a very nice achievement, I would say, and a contribution also. And is mainly interested in neurocritical care and neuroinfections. Next, Dr. Ajay Kumar Singh, a leader, a very prominent personality. You must have heard him at various occasions in several conferences, and he is the professor and HOD of Department Neurology of Aram Al IMS Lucknow, that is Ram Manohar Lohia Institute of Medical Science. He has 10 national and 32 international publications, and his achievements and awards. He has book chapters two book chapters. He has got Director's Appreciation Certificate from the Honorable Governor of Uttar Pradesh. He is also a member of several learned institutes, that is IAN, IMA, IEA, headache subsection, AN, and interestingly, his area of specialization is headache. So, next slide, please. So, dear friends, once again, we are thankful to all of you, and particularly today's institute and the leaders. Dr. Lakshmi, with your kind consent, shall we go ahead?
Yes, sir. Yes,
I
sir. Yes, sir.
want-
Yes, sir. We can handle. Thank you. Thank you so much. Thank you.
Right. So once you are there, I got a lot of courage, and
Sir, sir, we all get inspired by you. So thank you so much.
Welcome. So Professor Ajay Kumar Singh, thank you. Please take over from now and have the presentation from your side.
Okay, sir. Thank you, sir, for giving me this opportunity. And I hope in front of you, such senior faculty members and experienced person and very high quality teachers, we will be able to learn something from this case. And this is a case which is a patient presented with multiple cranial nerve palsy and headache with a young female patient. And we were able to reach at some conclusion in the last, but still I am not satisfied whether something missing or this is the final journey. So I'd like to invite Dr. Sangam Singh to present this case, and so we should learn something. Thank you, sir. Dr. Sangam,
Yes,
please start without wasting time.
Okay. So I'm starting my presentation here. Okay. Good evening, everyone. So today in the 58th chapter of the 58th chapter of 58th episode of Secrets of Neurology, my case discussion start with the rare and complicated journey of multiple cranial nerve palsies. So just a minute. Okay. So the patient particular, we had a patient of 25-year-old married female. She is right-handed, housewife, education completed up to graduation, and vegetarian by diet. Presented to our institute with a chief complaint of headache since last 3 months, with increasing severity and frequency since 1 month, and plus progressive visual loss in both eyes since 2 months, followed by drooping of left eyelid and facial deviation to left side since 1 month. Along with that, pulsatile tinnitus in both ears since 2 weeks. After that, coming to the detailed clinical symptom. Headache. Patient had 3-month history of headache, which was progressive daily headache, which was throbbing, moderate to severe intensity, holocranial initially, episodic, and now it is continuous, more severe since 1 month. It was associated with nausea and vomiting, but without photophobia or phonophobia, without any visual or any sensory aura. And it was not associated with any redness, lacrimation, tearing, or other autonomic feature. Along with that, patient also complained of history of transient visual obscuration intermittently. Coming to the next symptoms, progressive visual loss in both eyes, right more than left since 2 months. The subacute onset progressive dimness of vision initially in the right eye, followed by similar dimness of vision in the left eye without any orbital ocular pain or redness or swelling of the orbit. That progressed such that she could not see anything from her right eye, but retained some visual function in the left eye. After that, she developed left-sided ptosis and facial deviation to the left side since 1 month. And she developed the drooping of the. She also developed drooping of the left eyelid, which she started noticing 1 month back when she looked herself in the mirror and was noticed by her family member. And it was not associated with any local swelling or redness, and either this was not associated with any decreased sweating on the same side of the face. Following that, she also developed a droop. With the drooping of the eyelid, she also noticed that her face, especially her lips, is slightly deviated to the left side while smiling or eating. She also complained of drooling up saliva from an angle of mouth on the right side. Along with that, she also complained that she could not appreciate the taste of her food on the right side of the tongue and decreased hearing from the right eye. She also complained of pulsatile tinnitus in both ears since last 2 weeks. With this complaint and following that negative history, patient does not have any history of fever, any weight loss, does not have any aggravation of complaint with neck movement or any neck stiffness. There is no history of motor weakness or any sensory loss, no history of cognitive decline, behavior abnormality, no history of seizure, no history of any loss of consciousness in past. And patient does not have any history of tuberculosis in past or any contact history of tuberculosis patient. She denies any history of significant trauma. She denies any history of respiratory symptoms like cough or breathlessness at present. Personal history and past history. She is married, but with irregular menstrual cycle. She is a vegetarian diet, hypothyroidism, on 50 microgram thyroxine supplement since last 1 year. She has moderate obesity, on hormone replacement therapy since last 6 months because she was unable to conceive. No history of diabetes, hypertension, no history of addiction. She was married for 6 to 8 years, but she was unable to conceive. For that, she was taking hormone replacement therapy since last 6 months. Then coming to the symptom analysis. Patient had headache, 3 months of severe headache, initially episodic, now continuous with nausea and vomiting. I will at this point, the chances of primary headache are very less likely. So I would like to consider the possibility of the causes of headache because of the RAGE ICP. In this particular patient, the possible causes of RAGE ICP can be categorized by either reduction in the CSF absorption or blockage of CSF flow or any space occupying lesion or pseudotumor cerebri if other etiology are not found. So coming to the reduction in CSF absorption, the possible etiology could be meningitis, elevated venous sinus pressure due to blockage of arachnoid granulation. And coming to the blockage of CSF flow due to basal X0 tubercular meningitis with non-communicating hydrocephalus, including space occupying lesion like intracranial mass, abscess, multiple tuberculoma could be a cause. And if all possible etiology are excluded, possibility of pseudotumor cerebri like IS should be considered. Coming to the next symptom, bilateral visual loss with raised ICP. With the patient of a history of 3 months of a headache, possibly because of raised ICP, bilateral visual loss can be explained with the raised ICP. Because of raised ICP, there is a loss of pressure gradient and exoplasmic stasis of optic nerve. That may lead to the increased blind spot because of papilledema, and that may further lead to the vision loss. If this persists for a long time, this may cause secondary optic atrophy. Other than this, other possibility include can be considered, that is optochiasmatic meningitis, which is usually seen patient with chronic meningitis or pachymeningitis. Coming to the third symptom, patient has left eye ptosis. The possible involvement at this point we can consider third nerve involvement, as patient already gave history of no abnormal sweating or no abnormal decreased sweating on the left side of the face. So initially, to be third nerve pulse is to be considered first, and that can be further evaluated on examination based on the pupil size. If pupil size is normal or dilated, possibility of third nerve palsy can be confirmed on examination. Along with that, extraocular movement should be may be restricted. That can give us further clue to identify either etiology of ptosis as a third nerve palsy. Following that, patient had right facial palsy with impairment of taste sensation on right side. So possible localization for this is either cisternal or meatal part of the facial nerve. I am considering cisternal or meatal part because the part of the motor part of the facial nerve coming from the motor nucleus from the brainstem, and then come nervous intermediates that come from the nucleus tractus solitarius, and the parasympathetic fiber coming, all these fibers joins together near the cisternal part of the facial nerve, just where it enters into the cisternal cavity. So I would like to consider, if all these three are involved, I would like to consider possibility of facial nerve involvement at these possible sites. And at the, I would also like to add that this part of the facial nerve is also prone to raise intracranial pressure, because this part is very rich in venous plexus surrounding these areas. Then along with that, patient has pulsatile tinnitus. So the most common causes of pulsatile tinnitus are vascular, and for venous causes we can conclude possibility of IIH or turbulent flow of blood to the internal jugular vein, or possible thrombosis of the internal jugular vein. After that, I would like to summarize based on the just history. The 25-year-old female with severe headache and bilateral multiple cranial nerve palsies with hypothyroidism, moderate obesity, and on hormone replacement therapy. So localization for these symptoms will be the headache. I would like to localize because of raised ICP, involvement of either meninges or venous sinuses. And for multiple cranial nerve palsies, I would like to localize either vision loss due to raised ICP or because of involvement of extraaxial course of cranial nerve via meninges and other structures. So my differential diagnosis, I would like to include the chronic meningitis, pachymeningitis. Among this, the infective causes like tubercular meningitis, I would like to consider a country like India, where incidence of tubercular meningitis is very high. Other than this, inflammatory causes like sarcoidosis and IgG4 can be considered. Other than this, the rare causes, although rare, but carcinomatous meningitis can present as pachymeningitis, and non-Langerhans cell histiocytosis can also be present as a pachymeningitis. So other than this, my second possibility, I would like to consider CVST. Because of 20 to 30% of cases of the CVST may present as isolated intracranial hypertension. Following this, if these etiology are not confirmed on further investigation, possibility of IS should be considered. Then comes the etiologies and points in favor and points in regard. For chronic meningitis, patient of headache with multiple cranial nerve palsies can be seen. But in these patients, there is no history of any fever or any weight loss. That is points against the chronic meningitis. Then coming to the CVST, the patient has history of headache, which is the commonest symptom of raised ICP in CVST. Bilateral vision loss also seen in 12 to 13% cases of the CVST, and multiple cranial nerve palsy can also be seen. And for this patient has a risk factor like hypothyroidism, obesity, and hormonal failure. But the points against the CVST is that there is an extensive and only cranial nerve involvement in this patient, which is very uncommon but not rare. Other than this, I would, if all possibilities are excluded, IS can be considered because it also have the similar risk factor as a CVST. But the odd point for the IS that patient has asymmetrical vision loss and facial palsy is uncommon in case of IH. Although 6 to 8% of cases of IH have asymmetric vision loss. Any comments, sir?
Yes. Sir, hello.
Yes, sir.
So very nicely presented your history. As the classical teaching, we know that the pain sensitive structures are the scalp and meningeal arteries, spinal arteries, the dural venous sinuses, arc cerebri. All these are structures of pain sensitive. And careful clinical approach, understanding the pathophysiology, anatomy, and pharmacology of pain pathway is also important to approach this patient. And as you rightly said that there is distension, stretching, and other inflammation of these structures may lead to the pain. So these are the possibilities are quite common, and we should approach with the further examination and other findings. So
okay, sir. I will continue further, sir.
Yes. Any comment from other or panel members? So if there is no comment, we can proceed to the examination.
Okay, I am continuing to the examination. So the clinical examination, the patient was, there was no pallor, icterus, clubbing or cyanosis, no lymphadenopathy, no organomegaly. Blood pressure was normal, that is 110 by 60 mm of Hg, pulse was 80 and regular. Respiratory and cardiovascular system examination were normal too. Following that CNS examination, patient higher mental function were conscious, oriented to time, place, person. Memory, immediate, short-term, long-term memory were intact. Language were normal, including fluency, reading, writing, repetition. Attention was normal too, and MMSC was 30 by 30. Following that, came to the examination, the olfactory nerve, cranial nerve examination. Coming to the olfactory nerve, this was smell sensation normal in both nostrils. Coming to optic nerve, the pupil was on right side was 5 mm but not reactive. Left side 4 mm, sluggish reactive, no RAPD. Light reflex in right eye, absent, both direct and indirect. But in left eye, direct was sluggish reactive, indirect was not reactive. Visual acuity right on only perception of light, but in left side 6 by 18. which was not improving on the pinhole. After that, fundus examination showed the bilateral papilledema. The eyelid examination showed the mild left eye ptosis, and on extraocular movement examination for cranial nerve 3, 4, and 6, it shows right eye shows restricted in all gaze, including LR, lateral rectus, inferior rectus, medial rectus, and superior oblique. That means possible 3, 4, and 6 nerve palsy. Following that, left eye is mildly restricted in all gaze except preservation of medial rectus function. Coming to trigeminal nerve, the sensory examination, mild paresthesia in V1 distribution on the right side. Motor examination for trigeminal nerve was normal. Facial nerve, there is complete facial palsy on the right side, including the eyelid and the part of the lower, upper and lower part of the face. Following that, cochlear decreased hearing bilaterally was noted on examination. That was not present on history. Rainy test was air conduction was higher. Air conduction was more than bone conduction bilaterally, and Weber was not localizing to any. Rest of the cranial nerve, including 9, 10th, 11th, 12th, were normal. Coming to the motor examination, for motor examination, patient has a normal tone and power was normal in all 4 limbs. Sensory examination, including fine touch, JPS, vibration, pinprick was normal too. There is no signs of any extrapyramidal system involvement, no signs of cerebellar dysfunction, no meningeal sign, no necrosis, no connection. And these are the images of the patient that shows the first coming to the right side, we can see the patient has on the right lateral gaze, lateral rectus restricted. On the down, on the right side, on the right eye, we can see right eye is not able to go down gaze restricted. In the same, we can see there is a up gaze restriction. In the same, we can see there is a medial rectus restriction. In case of left eye, we can see the left eye is able to move medially on the right side, but it is not able to move downward properly. In this image, we can see that. At the same time, it is able to see in up gaze direction, but it is restricted. It is not in the full range. So we can see that patient has at least some gaze restriction in all gaze other except medial rectus in the left side. Along with this, we can also see that in this image there is a right-sided facial palsy and devisal of mouth to one side. Along with that, we can see the patient inability to close the right eyelid of the patient. And this image, we can see that there is mild ptosis on the left side. At the same time, this is the resting state of the patient. And we can see that there is a overactivity of the frontalian muscle. Coming to the next image. This is the fundus photograph of the patient that shows at least moderate to severe grade papilledema in both sides. And following that, we also done a pure tone audiometry for the patient, which showed bilateral bilateral high frequency hearing loss in both sides. After detailed examination, I would like to revise my diagnosis as 25-year-old married female with new onset severe headache with bilateral multiple cranial nerve palsies at 2, 3, bilaterally 2, 3, 4, 6, and 8, right facial, right trigeminal V1, and bilateral vision loss and papilledema with hypothyroidism, with obesity, and BMI is 32. And following that,
Sangam Singh,
yes, sir.
couple of things
Yes,
I
sir.
would like to know. Did you auscultate the patient on the skull?
On the skull or around the orbit or around...
The point for the postgraduates is whenever the patients have pulsatile tinnitus,
Yes, sir.
the auscultation on the mastoid or in and around the temporal region is very
Yes, sir.
important because sometimes
Yes,
the glomus jugulaire or some of the AVMs can always present.
Yes.
AVMs, they are notorious for stealing the blood from the ophthalmic arteries also.
Yes,
So
yes,
it
sir.
present with the blindness. Okay. Second
Yes,
thing
sir.
is in patients with IAH, they can always develop a secondary keratoconus fistula. Secondary
Yes, sir.
to the IAH. So auscultation over the orbit is also equally important. So these
Yes,
two
sir.
points which the postgraduates should remember. Just wanted to add that. Thank you.
Yes, sir. Okay, sir. Thank you, sir. Okay. Should I continue, sir?
Please continue.
Okay. Coming to the MRI images of the patient, this one is the T1 section that shows almost normal imaging, and there is no contrast enhancement of the meninges at the same time. Coming to the T2 section, T2 images were also normal. There is no flare hyperintensity in any part of the brain. Coming to the this flare sequence, we can see there is a tortuosity of the optic nerve on both sides. Along with that, we can see that there is a protrusion of the optic nerve inside the orbit. There is a flattening of the optic disc, indicating there is an increased intracranial pressure in our patient. At the same time, we can see there is no diffuse restriction in any part of the brain. So, based on this finding, we can conclude that there is a possibility of raised intracranial pressure, but there is no meningeal involvement, no intracranial source. So, few of our etiology has been excluded based on this MRI. After that, we also done an MRI angio and MR veno. MR venogram shows there is we can see on the left side, the sigmoid transverse sinus and sigmoid sinus are flowing continuously and continuous with IJV. But on the right side, we can see the sigmoid confluence of transverse to sigmoid sinus, and there is a flow restricted flow, or there is a discontinuation of flow from the lower part of the sigmoid sinus. So after that, we also do a contrast imaging, which show there is a large thrombus on the right side of the sigmoid sinus that I have highlighted with the red arrow, and this large thrombus has extended up to the lower part, upper part, proximal part of the internal jugular vein. In this image, we can appreciate. After that, we concluded that the patient has cortical venous thrombosis, and most of her presentation can be explained with the secondary to the raised intracranial pressure because of CVS, cortical venous sinus thrombosis. Following this, blood investigation revealed mild anemia that was 10.4. MCV was 119. LFT, KFT were normal. Inflammatory markers like ESR, CRP were normal too. Coagulation profile including INR and APTT were normal. Thyroid profile was done, which showed mild elevated TSH. ANA profile, APLO profile was negative. Serum ACE level was done once to rule out our possibility of sarcoidosis, which was normal too. Serum B12 level was 154 because she was vegetarian, and homocysteine level was elevated, that was 87 micromole per liter. CSF opening procedure was also done because one of the possibility was idiopathic intracranial hypertension. So the opening pressure was more than 40 centimeter of H2O. CSF routine examination, including cell count, protein, sugar were normal too. CSF was negative for gene expert testing for the tuberculosis, and gram stain and acid fast stain were negative too. Patient also, after that, we also do the thrombophilia profile, including antithrombin 3, cardiolipin antibody, beta-2 glycoprotein, factor 5 Leiden mutation, MTHFR gene mutation, prothrombin gene mutation, protein C levels, and homocysteine level. Above, all reports were normal except the homocysteine level was elevated, which was 79 microgram per liter. So after all these investigations, came to conclusion that the final diagnosis, that was headache with bilateral multiple cranial nerve palsies, bilateral 2, 3, 4, 6, 8, right facial, right trigeminal V1 due to CVS, which was likely provoked due to multiple factors altogether with obesity, hormone replacement therapy, mild anemia, hypothyroidism, and hyperhomocysteine. And this was the patient came follow-up image of the same patient. We can see the extraocular movements are the right lateral gaze is almost complete. Patient is able to see down gaze properly and able to see up gaze, and her left lateral gaze is also improved, and other down gaze is also improved in both sides. So most of the extraocular movement has improved in this patient, and her visual acuity was also improved significantly after 3 to 4 months of the patient. So I would like to conclude my case study.
So, I would like, sir, some experts comment from both of you in view of the above facts, because this young female who is taking OCP and suffering from obesity, hypothyroidism, and multiple cranial nerve palsy, with raised CSF pressure and findings suggestive of the internal jugular vein as sigmoid sinus thrombosis. We had tried to rule out some causes, but NMO spectrum disorder, which may be also sometimes present with this type of picture, raised intracranial pressure. So that we have not till now, we have not done investigated in that line, but most of the investigation has been done. I would like some comments from the experts. So guide me if anything left, or we can do something, some other thing. Thank you.
Sir, Professor Sudhir Shah, sir.
You just go ahead, Dr. Lakshmi, I'm listening.
Okay.
Kindly give your comments, yeah. Hello.
Hello. Yes, sir. This was the total brief journey of this patient throughout. Currently, patient is improving, but is there any other possibility or some other investigation which may go further ahead?
Sir.
I would like your comments, sir.
Yes, sir. Wonderful case, because it is the 8th now, 7th now, 8th now. There's a sensory neural deafness also there, no?
Yes, sir.
Yes, sir.
Yes, sir. On pure tone automacy. Yes, sir.
In fact, this is quite a very rare case, because the bilaterality of multiple cranial nerves because of the cortical venous thrombosis on the right sigmoid sinus it's a very wonderful case, because this is it's an eye opener for all the postgraduates that raised ICP can produce so much devastating effects on the nervous system. Second thing, what is very fascinating is this pulsatile tinnitus is one of the important symptom of raised ICP. This you should always remember. Most of the patients, even if you retrospectively start asking the patients about their tinnitus part, most of the patients will say that there is a tinnitus which they were able to appreciate. Third thing is, I just wanted to know there is a sequence in the MRV. It is called Attico MRV, and this Attico MRV is a very specific sequence which is done to assess what is called a combined conduit scoring system. This scoring system is used to assess the whether the stent is required, a venous stent is required, the transverse venous stent is required or not. And the recent advances in this area is, again, measurement of the diameter across the transverse venous sinus, across the transverse venous sinus to sigmoid and sigmoid to jugular, the gradient, the pressure gradient which they measure when they do a venography. They measure, this can be done in non-invasively also. There are methods to measure the pressure gradient across this. So these two things, sometimes, the fulminant IAH, where so much of loss of vision is impending, threatening of loss of vision and all. This patient is luckily she has improved so much, but there are cases where it is refractory IAH where these measures are required. Thank you.
Thank you.
Yes, Dr. Lakshmi, I am really impressed.
Yes, sir. Yes, sir.
Case is really very unusual, rare, and presenting with bilateral cranial nerves and
Yes.
the putative mechanism that has been discussed is really fascinating. And I must compliment, along with you, to the whole team and Professor Ajay Kumar Singh and his team for bringing out this wonderful case, showing that, showcasing, and putting it across. So thank you very much. And I'm really intrigued with the whole case. I would like to give a little more thought how one can really explain this beautifully, both the sides is in the cranial nerves. Wonderful, sir. Thank you very much.
Thank you, sir.
Dr. Sangam,
Yes, sir.
can you elaborate the pathophysiology behind the involvement of these multiple cranial nerves?
Yes, sir. I tried to explain some of the physiology. As in case of CVST, there can be various presentation for that, and in some cases some cases patient may present as isolated intracranial hypertension like presentation. So in case of this similar cases with raised ICP, the vision loss can be explained with raised ICP and papilledema because of itself. Because of raised ICP, there is a loss of pressure gradient between intraocular and the optic nerve. Because of that, there is a stasis, exoplasmic stasis, and that may lead to the increase in blind spot in this group of patients. And in acute phase, there is only subtle increase in blind spot, but on persistent, on chronic stages, this blind spot increases and patient may lose ability to see, and that may also lead to the secondary optic atrophy in some patients. Following that, in this particular patient that I have reviewed various literature, and involvement of seventh nerve that can be explained based on, because I already explained that the cisternal and meatal part of the facial nerve, there is a large venous plexus around this part of the nerve, and these facial nerve and venous system of this facial nerve drain into the sigmoid sinus directly through the superior or inferior petrosal sinus. So involvement of this sigmoid sinus can indirectly lead to the increase in pressure changes that may lead to the direct involvement of the facial nerve in this particular patient. But along with this, we will not able to finally conclude why there is a bilateral third, fourth, and sixth nerve involvement in this patient. That we thought maybe because of raised intracranial pressure, because cavernous sinus also drains through the superior or inferior petrosal sinus to the sigmoid sinus. So if there is a very significantly raised intracranial pressure, somehow these pressure may be transmitting to the cavernous sinus, and these cranial nerves, that 3, 4, 6, and V1 also involved because of these changes.
Yeah, you're right, Dr. Sargam. Actually, what happens is whenever there's an ICT, the draining veins, the ophthalmic veins, they become dilated and tortuous and have a direct impact on the cavernous sinus. Not only that, the back pressure will produce the venous hypertension, which is reflected on the cavernous sinus. Okay, that can produce the bilateral 3, 4, 6 as far as the pathogenesis of that is concerned. There are a few questions which requires to be answered in the question box. I'll just, how can CVST IIH explain the ptosis? We have already talked about that right just now. How it can be, the ptosis is partially because of the increased pressure in the cavernous sinus affecting and producing. The important part of this is this ptosis can be both sympathetic and parasympathetic. The one in the cavernous sinus, because the venous structures around the ophthalmic artery can also, they carry the pupillodilator as well as the fibers to the Muller's muscle. So one that the sympathetico-parasympathetic paralysis, which is sine qua non of localization in the cavernous, you will have to very carefully look for what is called a dilatation lag in the dog. That is one thing. Second, how is there? Somebody has asked how are our reflexes?
Her motor system examination was normal. Reflexes were normal.
The third question by Karthik. Did you do ONSF or shunting? Optic nerve sheath fenestration or shunting?
Yes, sir. In case of fulminant IS, we can go for optic nerve.
No, did you do in this case? Is what they know. This case is managed conservatively, no?
Yes, sir. We managed because patient has severe vision loss and severe headache. And when we did the lumbar puncture, her headache was relieved in 2 to 3 days. And after 1 to 2 weeks of follow-up, she started telling that there is an improvement in her vision. That's why we kept her in a close follow-up, weekly or 2 weekly follow-up. And on every follow-up visit, she responded with improvement of her vision. That's why we did not go for those shunting or fenestration.
One more question. Homocysteine, was MMA level, methyl malonic acid level was measured or not?
Yes, sir.
That was one question. Okay. And the last question.
I think only serum homocysteine and vitamin B12 level was measured, and others were not available.
Okay.
So
One more.
methyl malonic acid was not measured.
Yes.
Dr. V. Manwar has said, good evening, sir. We have come one case of one 62-year-old female with diabetes, controlled sugar, multiple cranial palsies, 5, 7, 8, 9, 10, 11, with a history of otitis externa recently, but CT brain MRI count was normal. CSF we proceeded, found cryptococcal infections, confirmed on culture and patient is immunocompetent with the controlled sugar. How much is the probability of having negative imaging in such cases? Invariably now, the cryptococcal meningitis in immunocompetent individuals is on the rise. So now it is slowly rising, especially after the pandemic of diabetes in our country. The fungal meningitis has taken a couple of leaps ahead of the other meningitis. And the cryptococcus is one of the important organism which has risen in the rungs. It's gone higher up now. We also see a few cases where there is immunocompetent patients developing cryptococcal meningitis, as against previously it was thought only immunosuppressed individuals. Is no more the case. Thank you.
Yes.
Is there any other questions from anybody?
Now, Dr. Lakshmi and Dr. Ajay Singh, please let me know, with this much raised pressure, how would it reflect in other symptoms of raised ICP like consciousness and seizures and focal deficits and vomiting and all? How much it is really corroborating with all this, or is plainly reflected in cranial nerves only?
Yes, sir. That's difficult to answer, because in this patient, pressure was very much high, more than 40 centimeters. But patient was not having, patient was absolutely walking and doing all her routine activity, although headache was severe. So she came with that and with multiple cranial nerve palsy. But she was not having other than that these symptoms, neither seizure nor any focal deficit. These were absolutely normal. There was no such focal findings in this case. That we could not explain. And other than that, in spite of this fundus photograph, there is a significant visual loss, which improved over the next few weeks. That was a dramatic improvement. Although we expected that there may be some optic atrophy, but in fundoscopy, there is no suggestion of optic atrophy. These were few important findings which are difficult to explain in this case.
Yes, absolutely. But that makes us wonder that without all these symptoms also you can have raised ICP with venous sinus thrombosis. So we have to keep in mind this possibility, and that is the best learning from this case. So we should do proper investigation in such cases, even though you don't have overt clinical symptoms and signs of raised ICP, and even the fundus is not reflecting that well, raised ICP. So I think it's a good learning point. Thank you, sir.
One more thing is, so the deep venous system, as long as the deep venous system is not involved, there is that operates as an alternative conduit for the drainage. The consciousness level is fairly well retained. The moment the CVT patients start losing become drowsy and more, that means the deep venous system is getting involved and the reticular activating system has getting impaired, and that is where we should be very, very cautious. Here, luckily, in spite of such extensive cranial damage, her deep venous system was unaffected, and that saved her. And in my opinion, that is what has saved her.
So how do you contemplate that their deep venous system was not involved at all? Do you have that typical pictures of deep venous system? Do you have any test to objectively tell that deep venous system is not involved in this particular case? Because our venogram, routine venogram, contrast venogram, they never mention about all those intricate details.
So usually the cortical veins, the cortical veins, when even when one twig gets thrombosed, the seizure is a manifestation, sir. Where the level of consciousness, for example, anything beyond the straight sinus, anything beyond the straight sinus where the vein of Galen or the internal cerebral vein, all these things are the part of the deep venous system. Once they start the basilar vein, all these things, you can always ask them to make a comment, because they are all, you even in the MRV, you'll be able to see the flow up to the vein of Rosenthal and all. You can always see those the way. And secondly, also you should very carefully look at the 3 major anastomotic vein, the superior anastomotic vein, inferior anastomotic vein, which both of them serve as alternative conduits from the sigmoid sinus and the transverse sinus. So the anastomotic veins are also, you should look for the patency. When there's severe venous hypertension starts happening, even the emissary veins also starts getting visualized.
I get your point there, but the point that I am making is when you have so much extensive involvement, right from the second nerve to third, fourth, sixth, and bilaterally with seventh and the involvement, all how do we expect that the deep systems and emissary veins and other things are not involved, and it spares consciousness and the cortex and there are no seizures or. So this is very unusual and very rare
Yes, sir. Yes, sir.
position. That is what
Yes,
I'm
sir.
trying to
Yes,
make
sir.
it.
Yes, sir.
Otherwise,
It is very rare, sir. Very rare, sir.
with all this involvement, you will certainly get something. When you're saying that pressure is more than 400 and all that, so that is what makes me
Very, very rare,
wonder.
sir. It is very rare. As you rightly said, sir, it's very rare.
Absolutely. But I think the explanation was fairly okay, and it is really a learning case. Whatever may be the final explanation, we have to keep our mind open that such situation may happen, and we should keep this diagnosis in mind and investigate accordingly. That is most important thing out of all. Okay. Thank you, Professor Ajay Kumar Singh, and Dr. Lakshmi. You may would like to put some concluding remarks.
Yes, sir. Thank you so much, sir. Thank you. I think we can hand over to them.
Thank you, sir. Thank you for giving me this opportunity to present this rare case and learn many things from your side, sir. Thank you, sir. Thank you.
And be prepared for the next round after next 40, 50
Okay.
episodes.
So,
Thank you, sir. Thank you. Thank you. Mr. Chadda, would you like to conclude from your
Yes,
side?
sir. Yes, sir. Yes, sir. Thank you, sir.
I
So,
think, Mr. Chadda, by now, after listening 58 rare cases, you should be given honorary DNB degree.
so nice. Okay, sir. Thank you. Thank you, sir. So,
Okay.
thank you, sir. Today we are incredibly grateful to all of you for joining us in the Secret of Neurology, and we concluded another enriched session of the Secret of Neurology, which is the brainchild of our distinguished course director, Dr. Sudhir Shah, sir, and Dr. Lakshmi Narasimhan, sir. On behalf of Intas Pharmaceutical, I, Arun Chadha, Vice President of the Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 58 months. We are deeply grateful to our esteemed course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for their ongoing guidance in developing this fantastic web series on the neurology, which will be undoubtedly a valuable resource for all the DM and DNB students. Today, 58th episode was made particularly valuable by excellent case presentation by Dr. Sangam Singh of RML Ram Manohar Lohia Hospital, Lucknow. The insightful case discussion led by Dr. P.K. Maurya sir and crucial learning points highlighted by Dr. Ajay Kumar Singh sir, Professor and HOD of Neurology in Ram Manohar Lohia Hospital. And it has been a great pleasure having you with us for the 58th session of Secret of Neurology. And thank you once again for your gracious presence. We eagerly anticipate your participation in the 59th episode of the Secret of Neurology on June 27th, 2025. Until then, stay safe and stay healthy. Thank you. Thank you to all of you. Thank you, sir. Thank you very much.
Good night. Take care.
Thank you. Thank you very much, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you very much. Thank you.
Good
Thank
Good
you.
night,
Thank you
sir.
for joining.
Good night, sir.
Thank you.